The next is about the tumors of the intestines. Among them, the first is about the polyposis syndromes, intestinal polyposis syndromes. Polyps are finger-like projections seen anywhere, and intestines, of course, are one of the areas where the polyps they tend to occur quite frequently, and they are quite troublesome from the clinical point of view. Clinical point of view, they are very difficult to be diagnosed, and a lot of confusing issues are there. Now, as such, the polyposis or disease where the polyps are presented, there are many, and rather they are named mainly depending upon the syndromes, the typical presentation of the symptoms. And for the sake of convenience, they are primarily categorized into two categories: non-familial polyposis, or they are also called as isolated juvenile polyps, which are of inflammatory origin, where there is no genetic tendency. Whereas the other is the familial polyposis. Familial polyposis again is produced due to the genetic constitution, and there are a lot of varieties of these which are presented there, which are not really very practically useful from the clinical point of view in the regular practice. But of course, the importance of these syndromes would be because they are presented with some other clinical symptoms together, and among them, the somewhat significant ones are: one is the Gardner's syndrome, where there will be polyposis as well as the osteomas and sebaceous cysts. Patients presenting with osteomas, masses in the bone, and multiple sebaceous cysts also may have a chance of polyposis, and when these three are presented together, that's called as Gardner's syndrome. Then polyposis presented with the brain tumors, and there again the major presenting symptom would be of the brain tumors, and it could be presented along with that genetic abnormality of the polyposis. Then it's called as Turcot syndrome. Then Peutz-Jeghers syndrome is another quite rather comparatively among others. This is a more frequent ones, where there would be a polyposis, ovarian tumors, and pigmentation of the lips of oral mucosa or peripheral region around the area. This is common. These three sets of symptoms are common in Peutz-Jeghers syndrome. And the Cronkite Canada syndrome would be where the patient would have skin hyperpigmentation, alopecia, and nail changes along with the polyposis. Osler-Weber-Rendu syndrome is where the patient have polyps with the hepatic vascular abnormalities, where there will be abnormalities in the liver, the blood supply of the liver. Then Goldfield syndrome is polyposis with the sebaceous cysts. Bloom syndrome is the patient would have growth retardation, and the aging would be faster. The patient would have more maturity symptoms, immune deficiency, malignant tumors along with the polyposis. Cowden syndrome are hematomas, and breast in the thyroid and GI cancers also may occur together, and so on. Smith syndrome, microcephaly, and polyposis in males, not the cancer. Now, anyway, these are certain of those established varieties of the polyposis syndrome. From the routine clinical point of view, the important is only the familial adenomatous polyposis and the ability to identify these polyps as early as possible. Difficulty in identification of the polyps is because of majority of the patients of colonic polyps are asymptomatic. In a good number of patients, because of the other clinical manifestation, like in a Peutz-Jeghers syndrome, when the patient has a pigmentation in the oral cavity, if you go for investigation, you may find the polyps as such, so on, so forth. And whenever the symptoms occur, the most common symptom is a rectal bleeding. Either it could be a chronic bleeding from the colonic polyps, which can present with the iron deficiency anemia, or only the occult blood test being positive, or many times if it is quite massive, it may be melena. A frank blood would be seen if the polyps are in the distalmost part of the colon or near the rectum. So rectal polyps, they may present with a frank blood in the stools, whereas colonic polyps, they may present with the either melena or many times coffee brown colored blood in the stools, or at times it may not be visible to the naked eye, only if occult blood test may be positive. But patient presents with the signs of loss of blood due to and anemia deficiency and symptoms could occur. Certain of the symptoms may occur as diarrhea or constipation. Patients may also have a bowel abnormality, and characteristically the stool caliber, the mass of the stool would be reduced, which also is a sign of the malignant growth. So the whole problem would be to differentiate it between the colorectal cancer and polyps. In general, all the polyps have to be considered as a precancerous condition. But the risk of the polyps becoming malignant, of course, we will come to that part next as it. Then rectal polyps, the distal rectal polyps can be detected by digital examination or physical examination, otherwise may be normal. So only the distal most part of the polyps may be palpated as such. Adenomas of the rectum and distal colon occasionally manifest as a syndrome of severe diarrhea or massive fluid and ejaculate loss. Rarely, this also can be a presentation of the polyps. Then occult blood test in the stools is the only dependable sign, but that too, it may be negative in a large number of patients. Now, because of these difficulties, the problem would be of making the diagnosis as such. Now, these are exactly what Sushruta has mentioned as the Sahaja Ashras, that genetic or familial polyposis, where there will be abnormality of the genes, and that's exactly what Sushruta has mentioned. Sahajani, Dishta Shonita Shukra Nimittani, Tesham Doshadeva Prasadhanam Kartavyam, Visheshata Yeshtani, Durdarshanani, they are difficult to be diagnosed. Parushani, they are firm inconsistency. Pansuni, Darunani, Antarmukhani, they are located deep inside and hence they are not easily palpable. And whenever you are able to palpate it, they are firm and they may be multiple, small as such. Teihupadrutaha, Krishaha, Alpabhuko, Sirasantutagatraha, Alpaprajaha, Shinaretaha, Kshamaswaraha, Prodhano, Alpagnipranaha, Paramarasascha, Tatra Grana Shirokshnatha, Shravanarogi. Such the mantra puja atopa hridaya upalepa arotika prabhivipidhyate. These are all the different syndromes which we have mentioned, like all the syndromes, Canada syndrome and so on. They are included in a single description by Sushruta as a Sahaja Arshas. So all those polyposis are described by Sushruta as a Sahaja Arshas. A confirmation of the diagnosis of polyps are only by the endoscopy. Endoscopy again, the colonoscopy is comparatively easier, and in the colonoscopy, the polyps may be visible as either localized simple swellings with the mucosal surface, or maybe the mucosal the roughness, or by CT scan or MRI scan, occasionally the polyps may be visible as such. In the colonoscopy, the visibility of the polyps could be of different varieties. Either it could be a pedunculated polyp as you see over here, or it could be a flat polyp as such, or it could be familial polyps where there could be multiple polyps which are presented throughout the mucosa, multiple rough small polyps. This is exactly what mentioned by Sushruta as palm suni, as such, where you will have multiple of them. Or there could be giant single huge polyp as such, or again a giant polyp of different sizes, different shapes as could occur, or multiple polyps in the colon. These are the possible different variations which could be seen under the colonoscopy in case of polyposis. And hence, all the issue is they are difficult to be diagnosed, and the clinical symptoms also will be misleading in case of the polyps. Peutz-Jeghers syndrome is comparatively among the other conditions is more common, and in that condition, the clinical symptoms could be because of the massive bleeding. The patient may have the clinical presentation of the bleeding from that area. Intussusceptions tend to occur in case of the polyposis. Of course, in the Peutz-Jeghers syndrome, the incidence is high. Even that rectal polyp prolapse also could be the presentation. Many of the patients of Peutz-Jeghers syndrome also would have nasal polyposis. Along with that, pigmented macules in the lips and digits. There will be pigmentation, dark pigmentation. Gynecomastia also could be additional clinical symptom in case of the Peutz-Jeghers syndrome. Now, whenever there are polyposis, the whole problem would be to decide whether the polyp has a high risk of producing malignancy or not. And every polyp has to be considered as a potential pre-malignant condition. But to predict the risk, the cancer risk prediction based upon the statistical analysis. The certain guidelines which are presented are, if a polyp is larger than 1 centimeter, then it has a high risk of malignancy. So giant polyps, they tend to have a high incidence of malignancy. If more than 3 polyps are found, then too the chances of malignancy are more. If there is a dysplasia seen, if the surface of the polyp has become irregular instead of being smooth, then too the chances of the malignancy are more. And if at all that dysplasia may be confirmed by histopathology after it is removed. And the only choice of the treatment is either removal of the polyp or resection of the whole that segment of the intestine. The segment of the intestine could be the other possibilities. Now, decision about this would be based upon either the risk of cancer as well as prediction of the risk of the cancer, as well as maybe the histopathological evidence. If there is a low grade of risk of malignancy and if there is a single polyp, then polypectomy, removal of the polyp is preferred. If there are multiple polyps and there is a high risk of the malignancy later, it's better to have the resection of the loop of the intestine and anastomosis, and this is the usual plan in case of the polyposis asset. As far as the polyps, whether they can be prevented or not, is another issue. There are a lot of confusing literature about that. There is whether polyps can be prevented or not is questionable. There is no definite evidence of the prevention, but there are certain theories or certain data which are presented as the preventive measures for the polyps. Now, those preventive measures which are recorded but not very confirmatory are calcium may have a protective effect. They may reduce the chances of polyp. Fiber in the diet also is having maybe a tendency to prevent or reduce the possibility of the polyposis, and the best evidence is cereal fiber. They put as aspirin also may be considered as a preventive measure in patients as such, and studies have demonstrated that a diet high in antioxidants has no impact on colonic polyp recurrence. Once the polypectomy has done and administration of the antioxidant diet, whether it has reduced the recurrence or not, the studies have demonstrated that it is not. There is no definite evidence. In one study, supplementary folate also was found to have no benefit, although this conclusion bears with the caveat that the tested population had substantial basal folate in diet. So, folate may have a protective effect as such. So, that's about the polyposis in brief, because the chances of you are making a diagnosis and you are treating a patient of polyposis is lesser. And I don't consider that polyps can be treated only with our conservative management. You need to go for surgical management, and the most important part is to confirm whether the polyps are having a high risk of cancer or not. Prevention of the cancer would be the main aim in the management of patients of polyposis. So that's about the polyps as such. Then the next part, the last part of this would be the tumors of the intestine. Among those tumors, the common types of the tumors are carcinoid and stromal tumors, lymphomas and sarcomas. The other two varieties which are comparatively lesser. So because lymphomas and sarcomas, there is no specific clinical presentation, we will not deal much about that. But I will be dealing with carcinoid and gastrointestinal stromal tumors somewhat in detail. Now carcinoid, the word carcinoid comes in because they are neuroendocrine tumors. These tumors, they have a property of secreting enzymes and maybe hormones also, and very often they secrete 5-hydroxytryptamine or histamine derivatives, and such tumors, they are of neuroendocrine origin and they are from the primitive cells in the gut wall, and the most common location of these carcinoid tumors is in the appendix. But it's not only in the appendix. Carcinoid tumors can present the other organs also, like lungs, mediastinum, thymus, liver, bile ducts, pancreas, bronchus, ovaries, prostate, or kidneys also. They can occur anywhere in the other parts of the body. The carcinoid tumors have a tendency to grow slowly and they have a potential for metastasis. Now, carcinoid tumors are classified as non-functioning and functioning based on their biological activity. That's whether they secrete 5-hydroxytryptamine or not. Based upon that, they are categorized as a functioning and non-functioning. The non-functioning tumors would not present the classical carcinoid syndrome symptoms, whereas the functioning would be presented with the classical carcinoid syndrome. I will come to that. What's carcinoid syndrome as such? So, identification of the non-functioning tumors would be very difficult, and they are identified only because of their mass effect. When they grow in size and they block the contents or maybe the passage, then only they are diagnosed. Whereas the functioning tumors, can be diagnosed based upon the typical clinical presentation as such. As far as the appendix and appendicitis is concerned, the tumors which occur in the appendix and they can produce the obstruction, and it can be a cause for the obstructive appendicitis, and any appendix which is removed is to be sent for histopathology, and then only you may be able to confirm whether there is a carcinoid tumor or not. And among the tumors which are presented in the appendix, 80% of the tumors which produce that appendicitis, which result in appendicitis, are carcinoid tumors. Then the other way classification of carcinoid tumors also is based upon their location in the gastrointestinal tract, like foregut, midgut, and hindgut based location. And the clinical symptoms may slightly vary depending upon the location. Like the foregut, that stomach tumors may present with more of the obstructive symptoms of the proximal area. Midgut in the small intestine symptoms like absorption, malabsorption could occur. Hindgut, the patient may have diarrhea-like symptoms. The classical clinical symptoms of the carcinoid is periodic pain, and particularly in the intestinal carcinoid, which tend to occur periodically. That's at regular intervals, maybe some once in a month, once in a fortnight, or so on, without any specific triggering cause. And often that periodic pain would be accompanied with the abnormalities of the bowel, like either diarrhea or maybe the constipation occasionally. And one of the other classical clinical symptoms would be, which are seen in more than 90% of the 94% of the patients, is cutaneous flushing, reddish color of the skin, both face and the limbs, as such, due to the 5-hydroxytryptamine episodes of the 5-hydroxytryptamine released as such. That because they are neuroendocrine conditions, and the color changes are very prominently seen in head and neck, with the warm feeling of warmth, itching and rashes, sweating, palpitation, etc. Upper body erythema and edema, salivation, sweating, excess of sweating, lacrimation, or diarrhea. These are accompanied with that flushing symptoms. And this is very typical of carcinoid. So whenever you have a patient which is presented with these typical features, usually we tend to make a diagnosis of allergic reactions. But the patients who do not respond to the so-called the standard anti-allergic treatment, then you have to suspect the carcinoid syndrome. And carcinoid syndrome, once it is suspected, the next part is to locate the carcinoid mass, which could be in anywhere in the body, anywhere in the gastrointestinal tract or outside the gastrointestinal tract, and hence the whole job becomes difficult. The other clinical symptoms will be diarrhea and malabsorption, which are seen in about 80% of the patients, where the diarrhea will be watery, bulky stools, and the bleeding or steatorrhea also may occur in these patients. Cardiac manifestations, another very classical clinical sign of carcinoid syndrome is a right-sided heart failure, and the tricuspid valve pathologies. Tricuspid valve regurgitation is very classical of the carcinoid syndrome, which doesn't occur in any other conditions. See, usually you will have the pathology in the left side. More frequent sides of the heart would be on the left side. Right-sided complications, right-sided valvular pathologies are very rare in other conditions other than that of the carcinoid. So, valvular lesions, particularly the right-sided valvular lesions, and there could be fibrosis of the endocardium also may lead to heart failure, tachycardia, hypertension in a good number of patients as well. Wheezing and asthma-like syndromes also can occur in carcinoid due to the same release of 5-hydroxytryptamine and histamine, and that can result in the bronchial constriction. Some lesions are, tremors also are relatively indolent and result in chronic symptoms such as cup and dyspnea. The patient may have tremor also. Or the patient may have a pellagra-like skin lesions with diarrhea and mental disturbance, which we may make the diagnosis of pellagra. Carcinoid crisis is another serious situation where symptoms of carcinoid tumors can be life-threatening because of the acute release of this 5-hydroxytryptamine, and particularly this crisis can occur after stress or following chemotherapy or anesthesia as such. The same frequency of the symptoms of the cardiac these symptoms of carcinoid syndrome based upon the statistical data. The flushing is seen in very high percentage, whereas the arthritis-like symptoms are seen in comparatively lesser number of patients. These are the flushing, diarrhea, heart, valvular pathologies, and so on. To differentiate between a classical right heart failure and a valvular pathology produced carcinoid symptoms are, in the right heart failure, dyspnea is the most characteristic symptoms. Dyspnea, fatigue, ascites, anorexia, or edema can be the main clinical symptoms. Whereas in the carcinoid syndrome, along with that signs of right-sided failure, the flushing, diarrhea, bronchospasm, hypotension, and tachycardia are the classical clinical symptoms. Based upon that, clinically you can make out the differentiation between a carcinoid symptom and a right heart failure as such. The carcinoid syndrome, the skin rashes which are seen, that image which I referred to in the previous slide, the typical rashes or flushing seen would be the same, and these are due to the ectopic hormonal manifestations as such, particularly 5-hydroxytryptamine and serotonin. That rashes which I have just mentioned, as I earlier, the flushing produced with the skin, they are typically seen as such. Now, to make out the diagnosis of carcinoid syndrome is quite difficult, and routine clinical investigations may fail to make the diagnosis. And there are lots of sort of biomarkers which are used, and they are now neuroendocrine tumors as a whole, that's carcinoid syndromes as a whole, would be very difficult to make out the diagnosis, and they need very sophisticated setup, and lots of new trends of making the diagnosis are coming up. And among those established biomarkers which are available now at present, the neuron specific enclaves biomarkers can make the specific diagnosis in a patient. So if it is positive, it is confirmatory of the carcinoid syndrome, but the sensitivity of this would be lesser. The other endocrine, these biomarkers, tests which are available, but not frequently done. Now, these tests cannot be done in a routine clinical laboratory. They need very sophisticated laboratories, and only a few of the centers in India can do these tests as such. So, from our practical clinical point of view, these biomarkers are of lesser importance, but in future, in due course of time, these biomarkers also may become more popular, and the tests may be available in routine clinical labs. So hence, you have to have some fair idea of the type of biomarkers which could be used to make the diagnosis of carcinoid syndrome. And as per the currently available data, neuron-specific analysis is considered to be the more specific test as such. Then typically, because neuroendocrine tumors as a whole are very difficult to be diagnosed, then typically it takes a very long time for the diagnosis. So initially you will always have some other diagnosis, and the patients may have the typical growth, primary growth, which can result for a long duration, and by about 18 to 20 years it may result in fatal complications. And most of the times, based upon, now this again is a statistical data, the exact diagnosis, correct diagnosis occurs almost around 14 to 16 years after the onset of the disease. This is the present situation of making the diagnosis global. I am not talking about our setup. See, in our setup like conditions, it may be still later that you may make the diagnosis of these neuroendocrine tumors of carcinoid. But the most of the times, the most common other clinical diagnosis done is irritable bowel disease. The patients, because of their typical clinical symptoms of bowel abnormalities, and often that the flushing and so on, which looks like functional symptoms. They are mostly diagnosed as a irritable bowel, and a correct diagnosis may occur quite late in such patients, and this is the current clinical situation about the issues like. So carcinoid crisis is when the patient would have a very severe flushing and very low blood pressure, palpitation, confusion, or even breathing difficulty can result in carcinoid crisis, which can be even fatal as such. Now, as far as the management of neuroendocrine tumors, carcinoid syndromes are, because of the difficulty and the treatment protocol, the standard protocol would be, you will also have to confirm these investigations by any of these investigations like ultrasound or CAT scan or MRI scan, PET scan or arterial scan, because for the diagnosis to be made out with ultrasound, the lesion has to be localized and the size has to be quite big, where surgery is possible. Whereas these tests become negative, and when you go for the next level of the test like angiography and so on, they are usually quite widespread, and hence the exact surgical treatment would be difficult. There you need to go for the other alternative treatment like chemotherapy and with certain new drugs as it. There are newer drugs which are coming up now for the endocrine tumors, carcinoid now, because I am referring to these issues because the treatment of this carcinoid disease and the whole research activities on the carcinoid disease is quite huge. Research activities are quite huge in the field of gastroenterology now, and it's one of the major new interests in the gastroenterology. And there are new concepts of treatment developing now, and at present the most common factor, this form of the therapy which is considered successful is angiogenesis inhibitors, new generation of the drugs which are used very costly and very rarely used in our setup. Whereas the earlier treatment was surgery and chemotherapy. This is how it was evolved, the treatment protocols were evolved. So that's in brief about the carcinoid tumors. Next is about the stromal tumors. Stromal tumors also are comparatively rare, and they are only less than 1% of the gastrointestinal tumors are. But when they are produced, they are of mesenchymal neoplasms. Because mesenchymal, they tend to have a rapid course of development. Clinical symptoms of stromal tumors also are very vague and usually non-specific abdominal pain, and the typical symptoms otherwise is early satiety or abdominal fullness, patient having a fullness in the abdomen, palpable masses. Occasionally it's not rare, of course, rare is the standard, but they can occur in a good number of patients. Malaise, fatigue, which are again vague clinical symptoms as such, and focal widespread signs of peritonitis when there is a perforation. Or these may even present with obstructive symptoms. Stromal tumors often present with the obstructive symptoms, dysphagia or constipation, and maybe obstructive jaundice depending upon the location. I had an opportunity of treating a case of stromal tumor in early, somewhere in 90s, 2005. That case was there, which was diagnosed in KMC, and then the patient came with the total intestinal obstruction in our setup. And without removing the tumor as such, we have planned a management which is quite interesting. Confirmation of the diagnosis is by MRI or PET scan, and it's also necessary for staging the disease. And the standard protocol of the treatment is surgery is the definitive treatment. Surgery would be removal of the tumor, but risks of recurrence is high. Now, with that patient whom I refer to in 2005, that patient came with obstructive symptoms, and the patient had a total intestinal obstruction and diagnosed as stromal tumor, but the patient was not ready for surgery there. And the interesting issue is when the patient came to our hospital as a last resort, the palpable mass, that tumor was palpable as such, and when we palpated that, if we could just mobilize that mass, the patient would pass the bowels. So what I did was I impressed upon the patient for a surgery, and instead of resection, what I did was a laparotomy and extraperitonealization. The same mass was kept outside the peritoneum so that it doesn't get retwisted and the intestine will be kept straight. And with that, the tumor as such, along with the tumor, without any other chemotherapy, patient survived for more than 4 years without much discomfort and was able to consume food properly, and the patient had a normal life for about 4 years as such. So anyway, the other treatment which is standard now is imatinib, which is now has become standard, and the cost of the treatment will be quite costly. A month's treatment would cost around 10,000 to 15,000 rupees now. So that's the other way. But the adjuvant therapy now has become somewhat standard as such. These are the issues about the stromal tumors as such. Now the next part is other cancers in general, the adenocarcinomas, the depend of the intestines. The intestinal tumors again could be of different location and they can present with the different manifestations. And the manifestations in general would be of depending upon the location, like mainly the bleeding and then the anemia. Now, when the colonoscopy is the standard protocol to make the diagnosis of these tumor conditions, and the typical appearance would be a rectal cancer would be seen as a fragile growth which is sessile and which is adherent to the wall of the intestines. This is typically what you see as the rectal cancer. Colorectal or colon cancers, they are seen as wide bulge-like features seen in the colonoscopy as such. As far as the colorectal cancers are concerned, the typical clinical symptoms are only the abnormality of the bowels and difficult passage of the stools. Now, World Health Organization has considered colorectal cancer as one of the areas of concern and has given certain key facts. And the key facts given by the WHO are, as I have copied it as such because it's when you have that kind of information from the WHO, it has to be presented as such. Colorectal cancer is the third most common cancer worldwide, accounting for approximately 10% of all cancer cases and is the second leading cause of cancer related deaths worldwide. So it's one of the frequent incident conditions. Predominantly affects older individuals, with the majority of cases occurring in people aged 50 and above. Several lifestyle factors contribute to the development of colorectal cancer, such as high intake of processed meats and low intake of fruits and vegetables, sedentary lifestyle, obesity, smoking, and excessive alcohol consumption. So, incidence of the colorectal cancers is increasing. Cancers are increasing now, and it's often diagnosed at advanced stages when treatment options are limited. Diagnosis is always late in general. Incidence and impact of colorectal cancer can be significantly reduced by implementing primary prevention strategies such as adopting a healthy lifestyle, avoiding risk factors, and practicing early detection through screening. So this is what the WHO has said about the colorectal cancer in general. The risk factors which are established are, the one is the age. The risk of developing colorectal cancer increases with the age, and most of the diagnoses would be after the age of 50. Family history also is quite characteristic. Family history of colorectal cancer is with genetic preconditions, and familial adenomatous polyposis also is one of the known causes. Now, importance of the colorectal cancer comes with the background of the polyposis disorders. Every polyposis disease is considered as a potential factor for the development of a cancer, and hence we have to consider that part. And the risk prediction, I have already quoted that statistical risk prediction issues like the size of the polyp and the number of polyps which is said about that. And the personal history is if the patient have a colorectal cancer before or certain types of polyps, they are at a high risk, particularly patients where they had a polyp once, and even after the removal of the polyp, they have a high risk of developing malignancy in due course of time. Lifestyle factors, particularly unhealthy lifestyle choices such as diet, processed meats, low in fruit vegetables, sedentary behavior, obesity, smoking, excessive consumption, alcohol consumption can assist. Now, World Cancer Health Research Fund International, it has given certain statistical data about the colorectal cancer, colon cancer, and the factors, lifestyle factors which can decrease or which can increase in the manner, and this is again a ditto copy of the what the Cancer Research Fund says about that. That being physically active decreases the risk of colon cancer. Consuming whole grains decreases the risk of colorectal cancer. Consuming food containing dietary fiber decreases the risk of colorectal cancer. Consuming dairy products decreases the risk of colorectal cancer. Calcium supplement decreases the risk of colorectal cancer. Consuming red meat increases the risk of colorectal cancer. Consuming processed meat increases the risk of colorectal cancer. Consuming alcoholic drinks increases the risk of colorectal cancer. Being overweight or obese increases the risk of colorectal cancer. Being tall also increases the risk of colorectal cancer. So that's about the factors which are known about the development of the colorectal cancer. The clinical symptoms of colorectal cancers are mainly changes in the bowel habits such as diarrhea, constipation, or narrowing of the stool mass. The stool mass becomes narrow. Blood in the stools, rectal bleeding, either bright red or dark or tar-like, any of that depending upon the location. So the same as that of the polyps. So, virtually, you cannot make out the difference of the clinical symptoms of a polyp and a colorectal cancer. The only issue is has to be confirmed by histopathology. Then abdominal cramps, pain or bloating that won't go easily with your usual antispasmodic treatment. Unexplained weight loss, then sudden and losing weight without trying as such. Feeling constantly tired and lacking energy even with the enough rest. Iron deficiency anemia. These are the typical clinical symptoms of colorectal cancer, and because of these atypical clinical symptoms, it's always difficult to make the diagnosis. Incidence of the colorectal cancer is quite high in the eastern countries like China. China is considered to be now the capital of the colorectal cancer because of the food habits consumed there. India, of course, the incidence is moderately high compared to many other countries. The incidence of colorectal cancer in India is comparatively lesser, but interestingly, it's increasing, and the prediction would be by 2020 is here the data, and the prediction of 2040 is quite significant because of the possible lifestyle changes. These are based upon the data available and the prediction of the possible incidence of colorectal cancer in future, and hence we need to be careful about that. The staging of the colorectal cancer, once the colorectal cancer is diagnosed, it could be staged based upon the typical TNM classification, or maybe the staging as staging 1, 2, 3, 4. The tumor classification or that your TNM classification mechanism or protocol is almost similar to that of the breast cancer, but the size would be, it also depends upon whether it invades the submucosa or not. T1 is when it invades the submucosa, T2 is invades the muscle layer, T3 is invades muscular propria into the serosal layer, or even not peritonized, not included peritoneum as such. T4 is when it invades the other organs nearby, and similarly regional lymph nodes, NX is no lymph nodes, and N0 no model metastasis, and the N1 and metastasis in 1 or 3 pericolic conditions. N2 is when 4 or more pericolic nodes are seen, and N3 is metastasis in any node along the course of vascular trunk, the vessels as such. And metastasis, of course, no distant metastasis M1, distant metastasis 1. Or it also can be made out with staged as stage 1, 2, 3, 4, almost same issues. Instead of TNM, you may even state that as a stage 2, stage 4 as such. Once the local colorectal cancer is diagnosed, the 5-year survival period with the current protocol of the treatment. The current protocol of the treatment is quite detailed, and where surgical resection, chemotherapy, radiation, all of them are followed. It depends upon if the localized disease is localized, limited in the early stage 1 or 2, then the percentage of survival for 5 years is 90.2%. Whereas if there is a distant metastasis, it reduces to 14.3%. So early diagnosis is the key, and early diagnosis when the patient has not yet developed the malignancy and in the stage of polyposis makes the prognosis better. And the poor prognosis factors predictions are if the size is greater than 5 cm and disease-free interval of less than 1 year, like Even after resection, suppose if a patient has a polyp and after the polypectomy, if the patient has a recurrence of the symptoms within a year, then the chances of prognosis are lesser. And if there is more than one tumor and lymph node positivity, carcinoembryonic antigen. Now, CEA is the tumor marker to confirm the diagnosis of the intestinal tumors as a whole, colorectal cancer. And if it is quite high, that also is predictive of poor prognosis. Treatment options are surgery, radiotherapy, chemotherapy, targeted therapy, immunotherapy. These are the different options, which we do not go into the detail. And one of the important factors which is now coming up, the latest would be more than 30 to 50% of the cancers are known to have abnormal genes, and majority of these patients can respond to anti-epidermal growth factor receptor antibody therapy. A new concept in the treatment of the malignancy is coming up, and maybe which is shown to have a better outcome with the least adverse effects as such. With this, we will end today's session, and if there are any questions, I will try to answer and then wind up. There are no questions, right? So we will wind up. And one announcement, next 26th, I will not be able to take the session. So 26th, there will be no class. I have some other commitment, right? Okay.